Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session I will be discussing a very important electrolyte abnormality, that is hyperkalemia. So if you see the overview of the topic, this is what I will be discussing in this topic. That is, first and foremost, you need to know that hyperkalemia, it is one of the medical emergency wherein if you don't treat, there will be death of the individual, and you need to know what is the cause of death in hyperkalemia. Subsequently, I will be discussing about etiology of hyperkalemia, what is pseudohyperkalemia, then pathophysiology, then what are the clinical consequences of the hyperkalemia, what will be the ECG abnormalities in hyperkalemia, management, and some multiple choice questions we will discuss in the last. Okay, right. So if you see the first question, what is the cause of death in patients with hyperkalemia? Systolic arrest, diastolic arrest, respiratory failure, congestive cardiac failure. Please remember, this is a very important question. Cause of death in patients with hyperkalemia, it is due to diastolic arrest. Okay. Now, you need to know what is the normal potassium levels. Normal potassium levels, they are around 3.5 to 5 milliequivalents per liter. That is a normal potassium levels, and less than 3.5 it is considered as the hypokalemia, whereas more than 5.5 it is considered to be the hyperkalemia, right? Now, after having said about the normal potassium levels, let me tell you that hypokalemia, most of the times it is well tolerated, but hyperkalemia, it is a life-threatening condition. Now, what are the etiologies which will cause the hyperkalemia? So, if you see the etiology of hyperkalemia, this can be the result of the two important things. Either due to excessive potassium release from the cells, right? Either due to excessive potassium release from the cells. This we call it as the transcellular shift. Right? This we call it as transcellular shift. That is, the potassium from the cell, inside the cell, it will enter into the extracellular compartment. Or impaired renal excretion of potassium. Right? Impaired renal excretion of potassium. Okay. So because of potassium, if it is present in excess quantity, it gets excreted through the kidney. But if there is impaired renal excretion of potassium, that is another important etiology which can cause the hyperkalemia. And for suppose, apart from these two, if the source of hyperkalemia is unclear, then a spot urine potassium can be useful. Right? A spot urine potassium can be useful. For suppose, if there is high urine potassium, right? For suppose, if there is high urine potassium, that is, if the urine potassium is more than 30 milliequivalents per liter, this will suggest the transcellular shift. Right? This will suggest the transcellular shift. And for suppose, if there is low urine potassium, right? If there is low urine potassium means less than 30 milliequivalents per liter, right? If there is low urine potassium, that indicates impaired renal excretion. Right, that indicates impaired renal excretion. Okay, that is what you mean by the word, that is what you mean by if there is low urine potassium. Okay, next, because when the kidney is failed, then there will be low urine potassium, that will be less than 30, and if it is more than 30, that will suggest the transcellular shift. Now, we have another terminology called as the pseudohyperkalemia. Please remember, hyperkalemia that is present ex vivo but not in vivo, that is known as the pseudohyperkalemia. Okay, so if there is hyperkalemia only in the blood sample, right, if there is hyperkalemia only in the blood sample but not in vivo, okay, this is what is your ex vivo. But if it is not in vivo, then it is called pseudohyperkalemia. That means within the body the potassium levels are normal, but if you take the blood sample, there is presence of hyperkalemia. Now, why is that due to? Right? Why is that due to? The leading cause of this condition is potassium release from traumatic hemolysis during the venipuncture. Okay, so this is due to traumatic hemolysis during the venipuncture. That is what is your pseudohyperkalemia, right? And this is the more common, or this is more common than suspected, and has been reported in almost 20% of the blood samples with hyperkalemia. So basically, please remember, pseudohyperkalemia is due to potassium release from traumatic hemolysis during the venipuncture. Now, apart from this, what are the other sources of the pseudohyperkalemia? The other sources of pseudohyperkalemia include the potassium release from the muscles during fist clenching. Okay, so potassium release can be there from muscles. Right, and that is during fist clenching. Right, that is during fist clenching. Okay, and that means whenever the blood sample is being taken, if the patient has clenched the fist, because of severe muscle contraction, there can be release of potassium into the circulation, and that can cause the pseudohyperkalemia. And apart from that, the potassium release from the clot formation in the blood collecting tube. Okay, potassium release from the clot formation in the blood collecting tube. Right, that is what is your pseudohyperkalemia. Okay, next, conditions where you will have pseudohyperkalemia is traumatic hemolysis. Number 2, from muscles during fist clenching. Number 3, potassium release from clot formation in the blood collecting tube in patients with severe leukocytosis. These are all the causes for pseudohyperkalemia. Next point is, what is the next step when pseudohyperkalemia is suspected? When pseudohyperkalemia is suspected, a repeat blood sample should be obtained. Right? A repeat blood sample should be obtained using the precautions to mitigate the suspected problem. Okay, so you need to repeat the blood sample. Then, now I said you about the etiology of hyperkalemia is, one is transcellular shift, the other one is impaired excretion, that is impaired renal excretion of potassium. Now coming to the transcellular shift, what are the causes which will cause the transcellular shift? So this condition is associated with the movement of the potassium out of the cells. And what are those conditions? Number one, acidosis can cause the transcellular shift. Number two, rhabdomyolysis. Right, rhabdomyolysis. Number three, tumor lysis syndrome. Right. Number four, drugs. I'll give you the mechanism how these conditions will cause transcellular shift. And lastly, blood transfusion, massive blood transfusion. Okay, so these are all the conditions which will cause the transcellular shift. Now, followed by that, first let me discuss about the acidosis. So, acidosis, what is the mechanism, how it will cause the hyperkalemia? The presumed mechanism for the relationship between the acidosis and hyperkalemia is competition between the H plus ion and potassium for the same site on the membrane pump that moves potassium into the cell. Okay, so you see here, this is the cell, right, and in which you have a channel. Okay, you have a channel, and this particular channel, it moves the hydrogen ion and as well as the potassium. Now, whenever there is acidosis, what will happen? Right, there is excess amount of the H plus ion, and this channel, it is responsible for the movement of potassium, and this channel is also responsible for the movement of the H plus ion. But for suppose, right, suppose if there is acidosis, right, if there is acidosis, when there is acidosis, what will happen? This channel is taken over by the H plus ion. The H plus ions will try to dominate the movement of the H plus ions across this channel, leaving behind the potassium in the extracellular compartment. And that is what is responsible for your hyperkalemia. So through this channel, because of acidosis, there is increase in H plus, and that increased H plus will try to move through this particular channel. Then followed by that, the another important condition is the tumor lysis syndrome. Tumor lysis syndrome, it is an acute life-threatening condition, right? So this is an acute life-threatening condition, and this tumor lysis syndrome appears within 7 days after the initiation of chemotherapy, right? It appears within 7 days after chemotherapy. Okay, so what this chemotherapy will do is, this particular chemotherapy will go and act on the tumors, right? And what this chemotherapy does, will kill the tumor cells, right? Will kill the tumor cells. And once the tumor cells are being destroyed, then there will be release of the potassium into the circulation. And there is also a question, which particular tumors are more prone for development of tumor lysis syndrome causing hyperkalemia? That includes non-Hodgkin's lymphoma, right? That includes non-Hodgkin's lymphoma. Now, in case of the tumor lysis syndrome, the characteristic features include the combination of multiple electrolyte abnormalities. That is, potassium is released into the circulation, phosphate is released into the circulation, and there will be also hypocalcemia. Why there is hypocalcemia? Because this calcium will combine with the phosphate, resulting in the calcium phosphate precipitate. Thereby, the ionized calcium levels will reduce. And along with that, there will be also hyperuricemia. Okay, so these are all the complications that you will, or these are all the electrolyte abnormalities you will come across in patients with the tumor lysis syndrome. Why is that? That is because of the chemotherapy which will be destroying the tumor cells. Next, followed by that, we have certain drugs that will cause the hyperkalemia, and one among that very important is digitalis. Now, what is the mechanism of action of the digitalis? Digitalis will inhibit the membrane sodium potassium exchange pump. Okay, so here we have the sodium potassium exchange pump. What the digitalis will do? Digitalis will inhibit the membrane sodium potassium exchange pump. Now, what is the action of the sodium potassium exchange pump? What this sodium potassium exchange pump will do is, it will push, right, or it will send 3 sodiums from the intracellular compartment to the extracellular compartment. And what it will do simultaneously? It will bring 2 potassiums from the extracellular compartment to the intracellular compartment. That is what the sodium potassium ATPase does. Now, what this digitalis will do is, digitalis will inhibit, right, or digitalis will block this sodium potassium exchange pump. Now, thereby the potassiums which are present in the extracellular compartment will not enter into the intracellular compartment, and that will cause the hyperkalemia. Okay, so among the drugs, digitalis is the one which will cause the hyperkalemia. Next, another important drug is the succinylcholine. What is this particular succinylcholine? Succinylcholine, it is an ultra short acting neuromuscular blocking agent. Right, ultra short acting neuromuscular blocking agent. That is what is your succinylcholine. Now, this succinylcholine, which is an ultra short acting neuromuscular blocking agent, what it will do is, it will inhibit the membrane sodium potassium exchange pump. Okay, even this succinylcholine does the similar action to that of your digitalis. Okay, so it inhibits the membrane sodium potassium exchange pump. Okay, So thereby what will happen? The extracellular potassium is not sent into the intracellular compartment. That is what is the action by your succinylcholine. Okay. Next, then followed by that, you take this life-threatening hyperkalemia. Life-threatening increases in serum potassium have been reported when succinylcholine is used in patients with denervation injury of the skeletal muscle. This is a very important point, right? So, if you have used this particular succinylcholine in patients with denervation injury, right? If you have used succinylcholine in patients with denervation injury of skeletal muscle, right, that will cause life-threatening hyperkalemia, right? And this is attributed to an exaggerated response to the depolarizing signals following the denervation. Okay, so that is about, so when will you have life-threatening increase in serum potassium levels? That is when succinylcholine is used with denervation injury of the skeletal muscles. Now, so if you see the drugs that promote the hyperkalemia, so if you see the drugs that will promote the hyperkalemia, we have the drugs that will promote the transcellular shift, that is beta blockers, right, beta blockers. Number 2, digoxin, right, and number 3, we have succinylcholine. Right, number 3, we have succinylcholine. So these are the drugs which will promote the transcellular shift, okay, causing hyperkalemia. And there are certain drugs which will cause impaired renal potassium excretion. And what are those drugs which will cause impaired renal potassium excretion? That includes the AC inhibitors, right, followed by that angiotensin receptor blockers, right. Next, we have potassium sparing diuretics, number 4, NSAIDs, so after having discussing about the drugs that will cause the transcellular shift and the drugs which will cause impairment of the renal excretion, let me discuss about what are all the conditions which will be responsible for hyperkalemia due to impaired renal excretion. So, the common causes of impaired renal potassium excretion include number 1, renal failure, number 2, adrenal insufficiency, number 3, drugs. Right, so these are the clinical scenarios where you have impaired renal excretion. Now, in case of renal failure, what happens is the kidney, it is not in a state to excrete the potassium, and that will be responsible for the development of hyperkalemia. Next, in case of the adrenal insufficiency. So, adrenal insufficiency, if you see, there will be decrease in corticosteroids, decrease in aldosterone, and as well as decrease in the weak sex hormones. Now, adrenal insufficiency, you have decrease in aldosterone. Right, there will be decreased aldosterone. So, whenever there is decreased aldosterone, the potassium is not excreted out, because aldosterone is a substance which will cause the potassium excretion through the distal convoluted tubule. Once there is decreased aldosterone, potassium excretion does not occur, and that will result in the hyperkalemia. Now, drugs. Already I have discussed the drugs that will cause the impairment of the renal potassium excretion. So these are all the list of drugs, right? I have already mentioned, but you see these ACE inhibitors and as well as the angiotensin receptor blockers. The ACE inhibitors and as well as angiotensin receptor blockers, what they do is they inhibit, right? They inhibit the renin angiotensin aldosterone system. So once they inhibit renin angiotensin aldosterone system, the aldosterone is not being formed. So once the aldosterone is not being formed, the potassium excretion does not occur. Okay. And the same story is with the potassium sparing diuretics also. So we have a group of drugs in the potassium sparing diuretics that is called aldosterone antagonists. Right, that is nothing but aldosterone antagonist. Now what these aldosterone antagonists will do is they will antagonize the aldosterone receptors. So once they antagonize the aldosterone receptors, the action of the aldosterone will not be there, and thereby the potassium excretion does not occur. Okay, so that is about the story of the potassium sparing diuretics. And you take the NSAIDs, non-steroidal anti-inflammatory drugs. These non-steroidal anti-inflammatory drugs are responsible for pre-renal type of acute renal failure, or it can also cause the papillary necrosis. So whenever there is development of pre-renal type of acute renal failure, or whenever there is renal papillary necrosis, the potassium excretion does not occur, and that will result in the development of the hyperkalemia. So these are the drugs which will cause impairment of the renal potassium excretion. Then followed by that, the blood transfusion. Right, followed by that the blood transfusion. So why there will be hyperkalemia when the blood transfusion is being done? Hyperkalemia, it is a recognized complication of massive blood transfusion. Right, it is a recognized complication of massive blood transfusion. Now why there will be hyperkalemia? See, the temperature used to store the RBC in the blood bank will be around 4 degrees centigrade. Right, the RBC, they are stored at around 4 degrees centigrade in the blood bank. Now at this temperature of 4 degrees centigrade, there will be shut off of the sodium potassium exchanger pump. So this will shut off sodium potassium exchanger pump. Right, this will shut off the sodium potassium exchanger pump in the RBC. So once the sodium potassium exchanger pump is shut off in the RBC, the potassium will not enter into the cell. Right, potassium will not enter into the cell, and that will cause the hyperkalemia. That is a mechanism why when the massive blood transfusion is being done, there is hyperkalemia. Okay, next, then followed by that, you have to know a clinical or a terminology called as cotopyriophagia. Now what is this cotopyriophagia is? One case has been reported in 1985. What is that case is about is the pica. What is pica? Pica is nothing but consumption of a non-nutritive material. Right, consumption of a non-nutritive material is called as pica. Now what this person has done is he has ingested 1500 burnt matchsticks. Right, so he has ingested almost 1500 burnt matchsticks. Right, now this burnt matchsticks, if you see the head, this is the head of the matchstick. So when the matchstick is being burnt, the head of that particular matchstick, it is rich in potassium chlorate. Right, it is rich in the potassium chlorate, and the habit of eating the burnt match heads is known as the cotopyrophagia. So this is one of the case reported in 1985. The cause for hyperkalemia is consumption of that burnt matchsticks which is rich in potassium chloride. Then another important clinical scenario where you can have hyperkalemia is the Gordon syndrome. Now what exactly happens in Gordon syndrome? Gordon syndrome, as such, it is an inherited disorder that affects the kidney, and what will be the clinical presentation in these individuals is the joints of the upper and lower limb are being affected. So there will be what is called distal arthrogryposis. Right, there will be distal arthrogryposis. So what happens here? There will be difficulty in the movement of joints of the upper and as well as the lower limb. Right, so there will be joint abnormality of upper and as well as the lower limb. Right, now in these patients with the Gordon syndrome, you see this is the normal distal convoluted tubule. What happens in a normal distal convoluted tubule? The potassium, it is secreted from the blood into the cell, and from the cell the potassium is secreted into the lumen and potassium is excreted out. But in patients with the Gordon syndrome, what happens is the potassium will be secreted into the cell, but from the cell it is not secreted into the lumen. Right, from the cell it is not secreted into the lumen. So this potassium will again go back to the blood, and that will cause the hyperkalemia. So in Gordon syndrome, which is an inherited disorder, the hyperkalemia is due to impaired secretion of potassium at the level of distal convoluted tubule into the lumen. Next, after having discussed about the etiologies causing the hyperkalemia, now you need to know what are the clinical consequences of the hyperkalemia. So the principal threat of the hyperkalemia is slowed impulse transmission in the heart. Okay, so there will be reduced impulse transmission right, slowed impulse transmission in the heart. Okay, now this slowed impulse transmission in the heart can progress to heart block, bradycardia and cardiac arrest. Okay, so this will progress to heart block, then bradycardia and next cardiac arrest. Okay, so this will be the clinical consequences of the hyperkalemia. These individual will have the cardiac arrest if he is not being or if she is not being treated adequately in a proper time. Now coming on to the ECG changes in patients with the hyperkalemia. So the earliest change is the appearance of tall, tapering, tented T wave. So you can see that T wave here, right? So the T wave, what you are observing here is tall, tapering, tented T wave. right? That is what you will observe in case of hyperkalemia. Tall tented T wave will be there in patients with the hyperkalemia, and these T waves, which are tall tented T waves, they are seen in the precordial leads, right? Predominantly seen in the precordial leads, and among the precordial leads you will observe them in lead V2 and as well as V3, right? You will observe them in lead V2 and as well as V3. So after having discussed about the earliest change, that is the tall T wave, the other ECG changes that you will have in patients with the hyperkalemia, it includes the PR interval and as well as P wave QRS complex. So the P wave amplitude, right, the P wave amplitude, it decreases, and the next point is about the PR interval. So what will happen to the PR interval is the PR interval will be prolonged, right? There will be prolongation of the PR interval, and eventually, right, eventually if you observe the P wave, the amplitude of the P wave is decreasing and the PR interval, it is increasing, but subsequently what you will observe is that there is no P wave at all. Right, subsequently what you will observe is that there is no P wave at all. P wave eventually disappears, and even if you take the QRS complex, the QRS complex will widen. Right, the QRS complex will widen, okay, and the final event is ventricular fibrillation or asystole. This will be the ECG changes. I'll repeat once again. The earliest ECG changes will be the tall tented T wave. Then followed by that you will have the P wave amplitude decreases and the PR interval will prolong, or the PR interval lengthens, and at one point of time the P wave eventually disappears and the QRS complex will widen, and the final event is the ventricular fibrillation or asystole. Now, after having discussed about the ECG changes, and the other method by which you can diagnose the hyperkalemia is estimation of the serum potassium levels. Next, now, how do you manage these patients with the severe hyperkalemia? So, when do we use the word severe hyperkalemia is when the potassium levels are more than, right, when the potassium levels are more than 6.5 milliequivalents per liter, then we call it as the severe hyperkalemia. Now, the management of this condition, we have three goals. What are those three goals? Number one, antagonism of the cardiac effects of the hyperkalemia. See, why is that we are very much worried in hyperkalemia? Because of the cardiac effects. So, the first thing is the antagonism of cardiac effects of hyperkalemia, right? Number two, transcellular shift of potassium into the cells. Right, transcellular shift of potassium into the cells. Number three, removal of excess potassium from the body. Right, removal of excess potassium from the body. So, this is how you will manage the hyperkalemia. Three things: antagonism of the cardiac effects of hyperkalemia. 2. Transcellular shift of potassium into the cells. 3. Removal of excess potassium from the body. Now, let me first, okay, you take the membrane antagonism. The first thing is the membrane antagonism. So if you take the membrane antagonism, what is the drug that we use is the calcium, right? We use the calcium gluconate. So if you take, so what will be the drug of choice for hyperkalemia? That is calcium gluconate. Now what this particular calcium will do? So this calcium, right, this calcium increases the electrical charge difference across the myocardial cell membranes. So this will increase the charge difference across the myocardial cell membranes. Right, it increases the charge difference across the myocardial cell membranes, and by increasing the charge difference across the myocardial cell membranes, it opposes the depolarization produced by hyperkalemia. So this calcium will oppose the depolarization right, will oppose the depolarization produced by hyperkalemia. Okay, that is what the calcium gluconate do, will oppose the depolarization produced by hyperkalemia. And what is the preferred calcium preparation? It is the calcium gluconate. Alright, next, then followed by that, what is the duration of response? The response to calcium is short lived, right? The response, it will be there only for 20 to 30 minutes. Right, it will be there only for 20 to 30 minutes. And please remember a very important point, it does not reduce the potassium. Right, it does not reduce the potassium. Okay, what it will do? It will only antagonize the effect of potassium on the cardiac cell. That is what is the important point related to your calcium gluconate. Next, then followed by that, what if cause of hyperkalemia is due to digitalis toxicity? Then how will you treat? See, calcium must be used cautiously in patients receiving digitalis because hypercalcemia aggravates the digitalis cardiotoxicity. Okay, so in this scenario of the digitalis toxicity, this calcium must be used cautiously. Right, must be used cautiously. Okay, now this calcium, why it has to be used cautiously in patients with digitalis toxicity? Because the hypercalcemia will aggravate the digitalis cardiotoxicity. Right, will aggravate the digitalis cardiotoxicity, right? And for patients receiving digitalis, calcium gluconate can be added to 100 ml of isotonic saline and it has to be infused over 20 to 30 minutes. This calcium gluconate, right, it is added to 100 ml of normal saline, and this solution, it has to be infused over 20 to 30 minutes. right? It has to be infused over 20 to 30 minutes, okay, right. And please remember, calcium is contraindicated if hyperkalemia is manifestation of the digitalis toxicity. So what you can do, you can give calcium gluconate, but per se ionized calcium you should not give if the hyperkalemia is a manifestation of the digitalis toxicity. And calcium gluconate also, how you should give, you have to dilute in 100 ml of normal saline and then you infuse it over 20 to 30 minutes. But ionized calcium is contraindicated if the hyperkalemia is a manifestation of the digitalis toxicity, right? Next, then followed by that, you need to know what is the other alternative calcium formulation. The other alternative calcium formulation that we have is the calcium chloride. See, when hyperkalemia is associated with circulatory shock or cardiac arrest, calcium chloride is a preferred calcium preparation, okay. So, because of hyperkalemia, if the individual lands up in circulatory shock or cardiac arrest, right, if the patient lands up in circulatory shock or cardiac arrest, then what you have to give is calcium chloride. This will be preferred to calcium gluconate. Right, this will be preferred to the calcium gluconate. And what is the advantage of the calcium chloride? This calcium chloride, the advantage compared to that of the calcium gluconate is it will improve the cardiac output, right? It will improve the cardiac output and thereby it will preserve the peripheral vascular tone. And you have to know that 1 ampule, right, 1 ampule of 10% calcium gluconate right, 1 ampule of 10% calcium gluconate, it has 3 times the elemental calcium in 1 ampule of 10% calcium gluconate. So this has almost 1 ampule of 10% calcium chloride, it has 3 times ionized calcium, right, 3 times ionized calcium then compared to that of 10% calcium gluconate, okay. That is what is the advantage of the calcium chloride. What it will do, it will improve the cardiac output of the individual. Then followed by the antagonism, that is membrane antagonism. You need to know the drugs which will cause the transcellular shift. Now the very important drug which will cause the transcellular shift is the insulin and dextrose. So among this insulin dextrose, insulin drives the potassium into the skeletal muscle cells by activating the membrane sodium potassium exchange pump, okay. So this insulin will drive the potassium, right, will drive the potassium into the skeletal muscle cells. Right, will drive the potassium into the skeletal muscle cells. Now, how it will drive the potassium into the skeletal muscle cells? That is by, right, that is by activating the membrane sodium potassium exchange pump. Right, that is by activating membrane sodium potassium exchange pump. So that is about the insulin dextrose. And this insulin dextrose regimen will decrease the serum potassium by at least 0.6 milliequivalents per liter. So this regimen will reduce the potassium by 0.6 milliequivalents per liter. That is what is the effect of the insulin dextrose. Now, why dextrose infusion is advised? Right? Why dextrose infusion is advised? See, a dextrose infusion is advised after insulin dextrose because there is risk of hypoglycemia at 1 hour. Right? So, to reduce the risk of hypoglycemia, you need to give the dextrose because insulin will reduce the blood glucose levels. So, in order to prevent that particular risk, we give the dextrose solution. Okay, but if there is hyperglycemia, dextrose supplementation is not required. Now, whenever you are giving this insulin, right, whenever you are giving this particular insulin, the peak effect will be there at 30 to 60 minutes. Right, the peak effect will be there at 30 to 60 minutes. So, measures that promote the potassium removal should be started immediately. Right, the insulin effect, it is temporary. The insulin effect is temporary, but the peak effect will be there at 30 to 60 minutes. Okay, next, then followed by that, the other drug is the beta-2 agonist. Even this beta-2 agonist will cause the transcellular shift. Right, will cause the transcellular shift. Now, what these beta-2 agonists will do? Beta-2 agonist, first of all, the beta-2 agonist that you will give is the albuterol. Right, that is albuterol. Okay, and the dosage of this albuterol is 0.5 to 1 milliequivalents per liter. Right, it is 0.5 to 1 milliequivalents per liter, and this particular albuterol will drop the serum potassium at least 4 times the therapeutic dose. Okay, so but the problem with the albuterol is it can cause the tachycardia. The side effects of the albuterol is tachycardia. Right, that is about the action of your albuterol. So please remember, these agents, they are not advised. The beta-2 agonist, it should not be given. Right, it should not be given for severe hyperkalemia. Right, for severe hyperkalemia, it is not given. Okay, now why? Because whenever there is severe hyperkalemia, as such, there will be the cardiac arrhythmias, and upon that, if you are giving albuterol, that also will cause tachycardia. So this can precipitate the arrhythmias due to hyperkalemia. Okay, next, now the another important point is about the bicarbonate. What is the role of bicarbonate? There are two reasons, right? There are two reasons to avoid bicarbonate for the management of severe hyperkalemia. Severe hyperkalemia, you should not give bicarbonate also. Okay, and short-term infusions of bicarbonate have no effect on the serum potassium levels. This bicarbonate, it can form complexes with calcium, which is counterproductive when calcium is used to antagonize the membrane effects of the hyperkalemia. So please remember, this bicarbonate you have to avoid, because whenever there is acidosis causing hyperkalemia, For the treatment of acidosis, you may give bicarbonate. But please remember, bicarbonate, it is avoided in patients with severe hyperkalemia. So, one reason is that this bicarbonate, it can form the complexes with calcium, right? And why are you giving calcium? You are giving calcium to antagonize, right, to antagonize the cardiac effect. Right, to antagonize the cardiac effect, you are giving the calcium, right? But what this bicarbonate will do? Bicarbonate will form the complex with the calcium, which is counterproductive. Okay, so you should not give bicarbonate along with the calcium gluconate. And the next important thing is short-term infusions of bicarbonate. Right, short-term infusions of bicarbonate, they have no effect on serum potassium. Right, they have no effect on the serum potassium levels. That is about the role of bicarbonate. Next, the next important thing is, how is potassium removal being done? So, whatever we have discussed is the drugs which will cause intracellular shift, that is your beta-2 agonist, then insulin dextrose solution. And what are the drugs which will cause the potassium removal? The excess potassium can be removed via the bowel. Right, removed via the bowel. Okay, and what is that drug we use is, it is a cation exchange resin. Right, it is a cation exchange resin. Okay, and the other way by which the potassium can be removed, it is directly from the bloodstream, that is by hemodialysis. Right, that is by hemodialysis. The potassium can be removed via the bowel. Next, then coming on to the cation exchange resin. Now, what is the name of that cation exchange resin is? It is sodium polystyrene sulfonate. Right, it is your sodium polystyrene sulfonate. So, this is also called K-oxalate. Right, this is also called K-oxalate. Okay, so this is your sodium polystyrene sulfonate, and this sodium polystyrene sulfonate, it is a cation exchange resin. Now, what this sodium polystyrene sulfonate will do is, this will promote the potassium clearance across the bowel mucosa. Right, this will promote the potassium clearance from the bowel mucosa. That is what is your cation exchange resin. And what is the route of administration of this cation exchange resin is the oral route of administration. Right, the preferable route is oral route of administration, or you can also give by retention enema. And this sodium polystyrene sulfonate, which is K-oxalate, it is usually mixed with the sorbitol. Right, it is usually be mixed with the sorbitol to prevent the concretions. Right, to prevent the concretions, you have to mix the sodium polystyrene sulfonate, that is K-oxalate, with the sorbitol. That is about the role of the cation exchange resin. Then coming on to the hemodialysis. Hemodialysis is another important method by which the potassium is being removed, and this is the most effective method of potassium removal. Okay, so this is the most effective method of potassium removal is by hemodialysis, right? And this hemodialysis can produce a 1 milliequivalent per liter drop in serum potassium after 1 hour of dialysis, right? So when you do 1 hour of hemodialysis, there will be drop of serum potassium by 1 milliequivalent per liter, and when you do a hemodialysis for nearly around 3 hours, there will be drop in the serum potassium by 2 milliequivalents per liter, right? By 2 milliequivalents per liter. That is what is the efficacy of the hemodialysis, right? Now let me just summarize all the methods of the treatment of the hyperkalemia, right? So I'll just show you a table, right? So first and foremost, antagonizing the cardiac cell membrane. The antagonization of the cardiac cell membrane, it is by the calcium gluconate, and the alternative preparation that you have is the calcium chloride. And where do you give calcium chloride? That is when the individual is having a cardiac arrest or is in a state of cardiogenic shock, then we give the calcium chloride. Okay, then drugs which will cause transcellular shift is the insulin plus dextrose solution, right? And the other important drug is the beta-2 agonist, and the potassium removal is being done by the K-exhalate, right? It is a resin which will cause the removal of the potassium, and the other method by which the potassium removal can be done is by your hemodialysis. So this is what is the treatment of the hyperkalemia, right? The summary that you have to remember is the plasma potassium, whatever we are seeing, is only the tip of the iceberg, because majority of the potassium, it is present in the intracellular compartment, right? Majority of the potassium, it is present in the intracellular compartment. Okay, so whatever we see the plasma potassium, it is only the tip of the iceberg in terms of evaluating the total body potassium levels. Okay, and the following points have to be remembered, that is, the potassium deficits are often larger than suspected in hypokalemia, even in mild cases. Okay, I'll be discussing this in the topic of the hypokalemia, but please remember, whatever the plasma potassium you are seeing is just only the tip of the iceberg. Okay, next, then followed by that, at which particular calcium level you will have the diastolic arrest. So what did I tell you? These individuals with hyperkalemia, the cause of death is the diastolic arrest. When the serum potassium levels are more than 8 milliequivalents per liter, that is the point when the individual will have the diastolic arrest. Okay, right. Now after having discussed about the theoretical part of hyperkalemia, let me discuss some multiple choice questions. Hyperkalemia, the best immediate management includes all except calcium gluconate, insulin drip, salbutamol nebulization, magnesium sulfate. So what is the drug which is not given in the immediate management of hyperkalemia? That will be your magnesium sulfate. See, calcium gluconate will antagonize the the membrane of the cardiac myocyte, very much required. Insulin and as well as salbutamol will reduce the potassium levels by causing the transcellular shift. They are also required, but magnesium sulfate is not required. Then all are used for the management of hyperkalemia except calcium gluconate, insulin plus dextrose, beta-2 agonist, then dialysis. Right? All are used for the management of hyperkalemia except we don't use beta-2 agonist. What we use is the beta-2 agonist. right? Your salbutamol and terbutaline, they are beta-2 agonists. We don't use beta-2 antagonist. What we use is beta-2 agonist. And the remaining all drugs, that is calcium gluconate, insulin plus dextrose and dialysis, they are all very much required for the management of the hyperkalemia, right? Next, then followed by that, you see another question. A 1-year-old male child is having the heart rate of 40 per minute. Blood pressure is only 90/60. The serum potassium levels are 6.5 milliequivalents per liter. What is the next best management in this individual? Ipratropium bromide, what is it? It is an anticholinergic drug. Adrenaline, it is adrenergic drug. Sodium bicarbonate, this drug will not be useful in the treatment of hyperkalemia. And the option that we have is calcium chloride. And even if you have two drugs in the option, calcium chloride is one option and calcium gluconate is another option, then go with the calcium chloride. Go with the calcium chloride. Why? Because the blood pressure of the individual is on the lower side. This calcium chloride can improve the blood pressure of the individual as well. So the answer is the calcium chloride, right? And you have to give intravenous calcium chloride. You have to give intravenous calcium chloride. Okay. Now, whenever you are giving this intravenous calcium chloride, let me tell you the effect of the infusion. The effect of the infusion will start in 1 to 3 minutes. Right? The effect of the infusion will start in 1 to 3 minutes. And this particular effect lasts for nearly around 30 to 60 minutes. Right, will last for nearly around 30 to 60 minutes. Okay, that is about the role of the calcium chloride. Next, now the other question is, which of the following is not recommended in the management of hyperkalemia? Albuterol, loop diuretics, peritoneal dialysis, 50% dextrose in water. Albuterol, it's a beta-2 agonist which will cause transcellular shift. Loop diuretics will cause the loss of potassium. That means it will cause the excretion of potassium. We use this loop diuretics. Peritoneal dialysis, let me tell you, either by hemodialysis or by peritoneal dialysis, you can remove the potassium. But 50% dextrose in water, let me tell you, it is of no use in the treatment of the hyperkalemia. Right? Next. Then, but what is the role of dextrose? Role of dextrose is like when you are giving insulin to prevent the hypoglycemia, we give this dextrose. Next, which is the most serious side effect with sodium polystyrene sulfonate? Intestinal perforation, rebound hyperkalemia, cardiac effect, respiratory arrest. Let me tell you, intestinal perforation, that is very common with sodium polystyrene sulfonate. And what is the recommended dose of the sodium polystyrene sulfonate? The recommended dose, it is around 15 to 30 grams of the sodium polystyrene sulfonate should be given, right? And this is combined with 33% of the sorbitol. This is combined with 33% of the sorbitol. So this particular suspension, should be given orally. That will cause the removal of the potassium. And the complication, if you see, intestinal necrosis, it is the most serious complication of the sodium polystyrene sulfonate. Then the next important question is, sine wave pattern on ECG is done when the serum potassium exceeds more than 6 milliequivalents per liter, more than 7, more than 8, more than 10 milliequivalents per liter. So what do you mean by the word sine wave pattern? Sine wave pattern means there is no P wave. You will have a wide QRS complex and there is no P wave and there will be wide QRS complex. So this is what is the sine wave pattern. You will have when the serum potassium levels are more than 8 milliequivalents per liter, there you will have this sine wave pattern. Okay. Next, then you see when the serum potassium levels are like 5.5 to 6.5 milliequivalents per liter, you will have tall tented T waves. When the serum potassium levels are in between 6.5 to 7.5 milliequivalents per liter, there will be loss of P wave. And when the levels are in between 7 to 8, there will be wide QRS complex. And when the levels are more than 8 milliequivalents per liter, then you will have a sine wave pattern. Then you will have a sine wave pattern. Okay. Next question is, decreased dietary intake of potassium is incriminated in leading to all except hypertension, stroke, congestive heart failure, diabetes mellitus. Let me tell you, whenever the individual takes less amount of potassium, that is implicated in the development of hypertension, that is implicated in the development of congestive heart failure, and it is also implicated in the development of stroke. This will be, but remember, diabetes mellitus will not develop when there is reduced dietary intake of potassium. Please remember, it's a very important point. Next, hyperkalemia is caused due to all of the following except alkalosis, acute renal failure, Addison's disease, excessive hemolysis. So let me tell you, it is acidosis. Right, let me tell you, it is acidosis that will cause hyperkalemia. Alkalosis will not cause hyperkalemia. Whereas acute renal failure, there is impaired excretion of potassium. Addison's disease, there is impaired excretion of potassium. Excessive hemolysis, the potassium from the intracellular compartment will enter into the extracellular compartment, resulting in the hyperkalemia. Okay, so alkalosis will not cause the hyperkalemia. It is acidosis which will cause the hyperkalemia, right? Next question is, what is the most rapid way of lowering the potassium levels? Albuterol, insulin drip, calcium gluconate, sodium bicarbonate. The rapid way of lowering the serum potassium levels is by the insulin drip, right? So if you see this table, this insulin drip, the onset of action will be there within 10 to 15 minutes and the action will last for 4 to 6 hours. The action will last for nearly around 4 to 6 hours. But the rapid method by which the potassium can be reduced is by insulin drip. Next, hyperkalemia presents with all except periodic paralysis, hemodynamic collapse, ileus, slow idioventricular rhythm. So ileus means what? There is decreased gastrointestinal motility. Where do you have decreased gastrointestinal motility is? That is seen in patients with hypokalemia. So hypokalemia will cause decrease in the gastrointestinal motility, right? And in hyperkalemia, periodic paralysis will be there, hemodynamic collapse will be there, and slow idioventricular rhythm can also be there. Okay, but decreased gastrointestinal motility is a feature of hypokalemia but not the hyperkalemia. Next, the cardiac rhythm seen with hyperkalemia is all except sinus arrest, sinus bradycardia, ventricular fibrillation, the torsades de pointes. So sinus arrest, sinus bradycardia and ventricular fibrillation can be there, but torsades de pointes, it is not the feature of the hyperkalemia. Torsades de pointes, it is seen in patients with hypokalemia. Torsades de pointes, it is seen in patients with the hypomagnesemia. Torsades de pointes, it is seen in patients with the hypocalcemia, but not hyperkalemia. Right? What is torsades de pointes? Torsades de pointes is, it is the scenario where the individual has a long QT interval, and this long QT interval will progress to the development of polymorphic ventricular tachycardia. Right, will progress to the development of polymorphic ventricular tachycardia. So that is what is the torsades de pointes seen in patients with hypokalemia but not in case of the hyperkalemia, right? And in case of the hyperkalemia, the arrhythmias that you can come across is the ventricular fibrillations and all can be seen. Next, which of the following genetic abnormality is associated with the development of hyperkalemia? So let me tell you the genetic abnormality that is associated with hyperkalemia. Options are the 2B hydroxylase deficiency, Liddle syndrome, Gentleman syndrome, autosomal dominant polycystic kidney disease. So please remember this autosomal dominant polycystic kidney disease. This is the one which is responsible for the hyperkalemia. Why? Because these patients with ADPKD, these patients land up in end stage renal disease. Right, these patients they land up in end stage renal disease, and that is the reason why they cause the hyperkalemia, because whenever there is end stage renal disease there is impairment of the excretion of potassium, and that will make the individual to land up in the hyperkalemia. Okay, so hyperkalemia is seen in autosomal dominant polycystic kidney disease. So these are some of the questions related to your hyperkalemia, and to summarize, hyperkalemia is a very important medical emergency. So if you don't treat the patient in appropriate time, the individual will land up in the cardiac arrest. Thank you very much.